So we're going to start off by introducing the clinical nurse specialist. So the first one is Kate. She is a clinical nurse specialist for Sexual Health and Rehab Service and has over 30 years of experience in clinical care, education, research, and program and policy development. Highlights of her career include leading a collaborative initiative to improve perinatal care for women with SCI and managing the project to develop provincial guidelines for sexuality and intimacy in care facilities in BC. Kate is a master's in nursing and has been an instructor with British Columbia Institute of Technology and the Faculty of Medicine at the University of BC. As clinical nurse specialist, Kate promotes evidence-informed clinical practices and programs which will lead the improved patient care outcomes in sexual health. We also have Rachel. Rachel graduated from Douglas College in 2010 with a Bachelor's of Science in Nursing. She developed a strong interest in sexual health while working with women in the community setting. This led her to become certified in reproductive health in 2012 and expand her practice to working with the youth and sexual health clinics. Rachel joined the sexual rehab team in 2017 and has developed a passion for her work in providing sexual health education and care to clients with disabilities or illness and their partners. We also have James on, who is ambulatory incomplete with 2 young children and is here to share his experience with the novel surgery. So we'll throw it over to the team.
Thank you, everybody, for joining. I'm really excited to hear that rec is coming on after us because I feel like there's a strong connection between recreation and sexual health. Maybe that'll come out a little bit during our presentation. Well, maybe sex is a recreation, right? So first I'll talk a little bit about our service, kind of who we are and what we do for anyone who may be unfamiliar with that. So we work with Vancouver Coastal Health, and yeah, we're a nurse-led clinic. There's a few of us. We have 2 other nurses that are not here today. We also work with a sexual medicine physician, Dr. Stacey Elliott, who we can consult when we need something that a doctor might need to be involved in. We also have a fertility portion of our service. So if somebody is looking to have a baby and they need a little bit of guidance or assistance with that, we have a urologist that we work with as well. Yeah, you can go on to the next slide, Kate. I think I actually was speaking to the next slide. Oh, and I'm very sorry, I forgot our land acknowledgement. Of course, we would like to acknowledge that we are living and working on the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Here where we are anyhow. I'm sure that we have people from all over. So we have 2 locations for our clinic. One is, of course, at the GF Strong Rehabilitation Center on the main floor. We have a big sign that says Sexual Health out of our front of our clinic, so you can't miss us. We also have a clinic at the Blesson Spinal Cord Center, which is right beside VGH, and we see most of our outpatients at the Blesson Spinal Cord Center. One very important thing to note, especially these days, is the large majority of our work can be done virtually. So whether that's by Zoom or by phone, it's whatever you're most comfortable with. Some people with a sensitive topic are a little bit more comfortable being in person, where other times people say it's easier for them virtually. So just note that. Next. Okay, so today we're going to talk a little bit about sexual health and incomplete spinal cord injury. It's difficult to get through such a broad topic, but we're going to do our best to touch upon some of the common questions and concerns, some of the strategies that we have to support people, and then have a bit of a discussion with our lovely peers about what they might suggest, because you are all the real experts here, let's be honest. So sexual health is really much more about the physical, right? The World Health Organization says that it's about the physical, emotional, intellectual, and social aspects of sexual being in ways that are positively enriching and that enhance personality, communication, and love. There's a lot of research coming out now that shows that sexual health is really connected to our sense of quality of life, to our overall self-esteem, and to our mental health. So sexual health is health, right? We can't have one aspect of our sexual well-being that is unhealthy without affecting the rest. So just to note that it's a legitimate part of our healthcare. And next. So sexual health rehabilitation, this term and this concept of care has been around since the 1980s, when our founder, Dr. George Saz, noted that many people, particularly with spinal cord injury, they needed a specific service to help them and really support them through this journey of adaptation. It wasn't simply enough to write a prescription for Viagra or to say you're going to figure it out at home. People wanted to talk about it. People wanted support. And so that's how sexual health rehabilitation came about. And it really should be part of a comprehensive rehab program. It's catching on more through different provinces and through the states, but I think BC has been really a founder of sexual health rehab. And so really it's about a process of walking alongside people with whatever their values and beliefs and stage of readiness might be to achieve sexual well-being. And next, please. So our kind of founding principles with our service are that we want to work with people to do three things. One is to maximize potential. So what does that mean? It means that we're helping and supporting people to explore different ways that you can still be a sexual person and feel good about your sexuality. And so not everybody after spinal cord injury will struggle greatly in this area, but some people will, right? And so we're there to help you kind of realize where you can get to and that you can still have a sexual life and be a sexual person. Also to note that I would like to say that there are a lot of positive attributes that having a spinal cord injury can sort of nudge you towards. So oftentimes people with spinal cord injury are very creative, they're very resilient, they're very adaptable, and using all of those skills that you learn through life with a spinal cord injury can sometimes be translated into the sexual health part of your life. Adapting to limitations is really something that everybody has their own timeline on, right? So there are certain things that maybe you could do before that now you can't. And this might be a psychosocial aspect, so it might have to do with your confidence. This might be a biologic aspect, so it might be, that it takes time to rebuild neural pathways. Or perhaps it might be even a shift in values that needs to happen in order to adapt. And the third and last one is remaining open-minded. So we really encourage people to have this idea of like a beginner's mind. So an attitude of openness, a lack of preconception, being able to acknowledge that new ideas that you haven't thought of or tried might be something that could be positive. Identifying your expectations around what sex needs to be, throwing that out the window and kind of eliminating like the should from your vocabulary when it comes to sex and sexual health. Easier said than done, but that's why we're here to support you. Next. So some common questions and concerns that we see in our service, couldn't list them all here, but generally a sense of distress around the fact that your body is different, right? Perhaps it's giving you a sense of sadness, frustration, sometimes grief even, right? That things, you lost a part of your life that was really enjoyable and that, was a part of you. Desire, a loss of desire. You know, people are like, in my brain, I want that part of my life, but my body is just not there. And a lack of desire is super common, whether you have a spinal cord injury or not, just to note. My sensation is different from before. You know, maybe you have a dulled sensation, maybe you have hypersensitivity that's really bothersome and it's difficult for your partner to touch you. So, you know, different types of changes to sensation can certainly be, you know, difficult for people in this area. And communication. So maybe it's telling a potential partner about what's different in a sexual situation or how you manage your bowel and bladder, or maybe it's a current partner and it's like, you know, the way that we were doing things before in terms of intimacy was working and now it's not. I don't know how to talk to them about it. So those are all things we can navigate. So at this point, you know, we do want to talk about body image and identity, but I also thought that it could be a good time to talk to James a little bit about his experience with adapting to changes in body image and self-identity after your spinal cord injury. Yeah, so what was that like for you, and how did that show up for you, if it did?
Uh, I really struggled with with adapting to my new body, and I'm married at the time, and I worked closely with Leslie, and I it didn't necessarily go too well with in my particular situation because my oh sorry because I wasn't adapting particularly well to the sensory changes. The other elements, I felt like I could explore, but I had a really difficult time accepting that the whole right side of my penis, which wasn't, didn't feel anything. So, yeah, and this definitely impacted my mood, and I was kind of prone to being rather depressed. And yeah, I mean, I'd like to say that just relying on the drugs was enough, but during sex, it really was hard to be engaging in intercourse and not being able to necessarily feel what my partner is doing, or even in other sexual activity. So I struggled, yeah.
Thank you for sharing that, James. I think it's really, I know it's a difficult subject to talk about, but I think it's important that, you know, others are able to hear your experience, because I think it is quite common, right? And it can be even more hard to talk about when someone might ask, like, why are your mood seems different, right? And you're like, well,
Mm-hmm.
not the easiest thing to talk about at a dinner party, perhaps,
No,
right?
no, exactly. And you know, I don't want to. There are a lot of people who don't have partners, but it's hard it's hard enough to, you know, be open-minded and adventurous with your own sexuality and accepting its changes. But you know, especially with regards to toys and other things, but it may not be the case that your partner is on board with toys and with being open-minded, or as open-minded as you know you need to be, even though the intention might be there. They're, you know, they might be disappointed in some way, you know, that their sex lives have changed too. So that's another dimension.
Maybe I'll just ask one more question along the lines of sexuality and self-identity, right? I think that there is a crossover there, right? And do you feel that maybe this kind of had an impact in your, like, outside of the bedroom? So, you know, your kind of feeling of self-confidence in day-to-day life, or the workplace, is that something that you noticed, or?
With regards to the workplace, I'm not too sure, but certainly out and about in the world and socially, I can tell that people would want to ask about that particular question, and I felt as though I needed to explain that now that I had prostaglandin, and I was really open about talking about it, that everything was back to normal, and that's fine. And I didn't really talk about the sensation, but inside I definitely harbored a great deal of insecurity, I think, around my sexuality that then, of course, like does bleed into one's sense of confidence overall. Yeah.
Thank you for sharing that. I hear that so often that, and I haven't figured out the sort of psychology behind it around why people think it's okay to ask somebody with any kind of physical disability about their sexual life, because it's just such a personal question, but I hear it way more often than you should. So I'm sorry about that happened. And yeah, I when I work with patients, I sometimes unfortunately have to say, maybe we come up with a bit of an elevator speech to have something to say back to someone in that moment, right? Because a lot of the people that I speak to, they feel so caught off guard in the moment. And then they go, I wish I would have said this or that, right? Not that that's a solution to this kind of inappropriate social issue, but just something that I've done when working with clients. But Kate, should we kind of move on to the next slide? Okay.
Sure. Thank you. And thanks, James, for being so open and sharing your experiences with us. We really appreciate it. And like Rachel said, it's really tricky. And I think I'm just reminded of when we were talking about identity, body image. I'm reminded about someone I saw in this service many years ago, and actually this young woman accessed our service for the reasons that she was having urinary, she'd pee during sex or during orgasm. So that was the reason she came to see us originally. And then we worked with her physician and got her on medication. And so that issue was no longer an issue. But then what really became apparent to me was the body image and how she felt about herself as a person, as an asexual person, was so profoundly, I want to say, damaged. And this is a long time ago, but she described to me the fact that, and I've heard this a lot from people about like invisible disabilities and how the expectations of others, like in the workplace. And I think when we met earlier, you described something like this, like people expect certain things of you and they almost like expect you to have the same roles at work or at home and whatever. And for this individual, I remember she was not able to wear high heels anymore. And although that sounds so minor, like, in the big picture things, for her, that was her identity. That was how she presented herself, like as an attractive person. And so not being able to do that. So that's something we talked about a lot. And I connected her with psychology to talk more, and a counselor. So it did get better over time, but I just always think about that person and the struggles that we talked about.
Yeah. It's like you're no longer a participant in the world of sexual beings. It's like you've been kind of removed from that slipstream or from that like world.
Yeah.
Yeah. At least that's how I
Which is crazy because like we're all sexual beings no matter what, right? And but how we express that can differ. So yeah, okay, I'll move on. We can I want time for a discussion with the group too. So okay, I will go back to my slides if I can find them. Okay, so to just build on what we were talking about body image, and I'm going to talk about, because one thing that body image can affect is desire. And we always think about this spontaneous desire. And that's something that we think about, like sexual drive, libido. We think about it as feeling like a horniness, feeling horny. So that's definitely can occur, but what's more common is this other form of desire, and that's responsive or triggered desire. So even though you may not have that sexual hunger anymore, if circumstances, context, everything is in alignment, you can access this responsive triggered desire. So I just wanted to spend a moment and just talk about this because it is such an issue for people. It's a question that comes up a lot, like, why don't I feel like being sexual anymore? I don't feel like a sexual person. So there has just been research into this subject, how reasons for sex, reasons to engage in sexual activity, and there's avoidance reasons, and I can't see that, but it's approach reasons. So for example, you might want to have sex because you want to feel close to your partner, and then on the other spectrum, you might want to have sex to avoid an argument. So that's an avoidance reason. But yeah, the research says there's 236 reasons that we have sex, that human beings have sex, which is crazy to me. There's that many. I don't know. I can't see your faces, but I don't know if you're as astonished as I was. So spontaneous desire. So sexual stimulation is really important in this cycle of desire. So what I mean by that is any kind of sexual stimuli that you interpret, and this could be you interpret from the brain, etc. So if the stimuli is there and it's a positive stimuli, we also think about the context. So is the context of the sexual encounter a positive one? Are you feeling comfortable? Are you undistracted? Or are you in a private setting? Are you relaxed? Like what is the context? That you know, is it, if it's not private, or are you worried like the kid's gonna come in the room or the dog's gonna jump on the bed, right? That's not kind of the most conducive context for desire. And then of course the brain is our processing center. So it will tell us, like it will give us the red light or the green light to go ahead. So when we think about having a spinal cord injury, we think about there could be biological factors at play here that interfere with desire. So things like low testosterone, side effects of medication, and there can also be those psychological things like we talked about, body image, pain. There could be spasms, fatigue. So all those things can interfere with this cycle. But if everything's positive, then we can have sexual arousal. And by that, I mean the mental and the physical part of arousal. And I'll talk a bit about that in a minute. And then that will lead to more responsive desire. So in other words, when you start off on this wheel, you may not have that desire. You may be kind of going through the motions, but it's kind of like when you're not hungry, but then when you have an appetizer, then all of a sudden you're like, you want more food. So it's kind of like the same thing. And then you get that urge to experience sexual pleasure or enjoyment. And then finally, if you have a positive experience and you have those positive sexual enjoyment and outcomes, then you have more motivation and more reasons for sex. To engage in sexual activity, either with yourself or with a partner. So I know that's very complicated, and bottom line is sex is complicated and desire is complicated. So let's talk a bit about sexual stimuli. So this is really how your body responds to sexual stimuli is what we call sexual response. And this encompasses all these things you see. So it may or may not encompass orgasm. It may or may not encompass genital and body arousal, so that muscle tension that you might feel during sexual stimulation. It could involve engorgement of external genitals. It could involve lubrication, mental arousal. Body arousal could be like heart rate increase and flushing. And hopefully there's pleasurable sensations. So that's why I wrote pleasure as in capitals there. So what do we see after having for someone with a spinal cord injury? So in terms of sexual response, and some of you may already know this, but we really look at 2 different pathways. And so depending on the level and completeness of injury, we would anticipate different changes. So the 2 pathways we talk about are psychogenic and reflexogenic. So if the pathway from the brain going down the spinal cord to T10L1, if that pathway is open, we do see some arousal in the body. So in the genitals, for example, you might see like engorgement of the genitals, for example, lubrication, etc. So that's one pathway. And then the second pathway is from direct stimulation to the genitals. So you touch, or someone touches the genitals, and those messages get sent to the sacral part of the cord, so S24, and then sends messages back, and then that's how you get that ongoing engorgement and sexual response. So you can see from this diagram that depending on the level and completeness, you might get different sexual responses happening. There's also this inhibition pathway that the reflexes that I talked about in the S24 reflexes, they won't work unless you remove that inhibition. Yeah, that's all I'll say about that. And there's lots of big words, but we won't go into that.
I'm not really understanding that. What do you mean by inhibition?
Yeah.
The inhibition. So inhibition. So people understand this in terms of like when you're young, you don't have that inhibitory, that higher. It's called a supratentorial inhibition. So when you're little, like when my baby boy was little and I changed his diaper, he'd get a reflex erection because that inhibition pathway isn't present yet. So around puberty, that's why you see like sometimes when young kids get in front of the class and they get that spontaneous erection because they can't help it and there's no sexual thoughts or anything going on. It's just because that pathway to suppress those reflexes, that's what inhibition is. And develops around puberty. Does that make more sense?
Mm-hmm, mm-hmm.
Kind of.
One more question.
Yeah.
This slide, is this how a healthy person would be, or is this after injury?
Yeah, so this is for anybody. Yeah, I mean, healthy. Yeah, this is the regular pathways for everybody.
The rest of the population kind of.
Yeah, these are the pathways that we talk about that everybody has. So depending on your level and completeness of spinal cord injury, they might interfere with these pathways.
I see.
Does that make sense?
Yes.
Kind of.
Okay, last question.
So me being a T9, does that mean that those nerve endings aren't going to get down to 10 and L1?
Right. What we often see in someone with a T9 injury is that they might have some interference, again, depending on completeness, in that psychogenic, which means when they think sexual thoughts, the messages may not get through and they may not notice like swelling or in the genitals. However, the theoretically, the sacral reflex will be intact. So from touch, you might get that genital engorgement and sensation
Mhm.
of pleasure.
Okay.
Yeah, so it's, and you know, for people with incomplete injuries, you never say never. Like it's always a bit of a mixed bag, but I'll go into that a little bit
Okay.
in terms of pleasure and orgasm, because that's coming up next. Is that okay? But we can come back to this later if people still have questions. I'm sorry, I can't see your faces, so I don't know who's asking. But thanks for the questions. Okay, so let's talk a little bit about pleasure and orgasm. So I know, and depending on like how we were raised, how we learned about sex, orgasm is sort of held up as like kind of the holy grail or the pinnacle, be all end all of sex. Whereas reality, we know that's not the case. But it's important to know what does orgasm actually mean. And the scientists, it's actually researchers and scientists, they can't really agree on a definition. So it's quite a complicated topic. But bottom line is it's the brain's interpretation of signals that lead to a release, usually associated with pleasure. And this may be triggered by genital stimulation or by non-genital stimulation. So that's interesting, right? So the non-genital stimulation, so it could be anything from like prostate pressure. It could be the contraction of the muscles in the perineum, and it also could be other parts of the body. So we hear some of our clients talk about other erogenous zones, like their ears. We know that people have orgasm through tantric excitement in their dreams, in their sleep. So there's all sorts of non-genital ways of having that orgasm or that pleasurable release. And we can experience pleasure without orgasm. In fact, so in other words, orgasm is not the only measure of a satisfying sexual encounter. And actually more and more, Rachel and I were at a sex day last year, I think, and they talked a lot about pleasure as the measure. So I thought that was really interesting. What might be interesting to this group is that for people with spinal cord injuries, we see the literature says between 40 and 50% of individuals do report experiencing orgasm. And the more incomplete your injury and the more genital sensation you have, the more chance you can relearn this experience of climax, of sexual release from genital stimulation. So I thought that's quite interesting. Maybe it's something you already knew. Yeah, okay. I just want to talk about, and maybe at this point, James, I wonder, because you did share a little bit about your sensory changes and the challenges that are involved in that. Do you want to speak a bit more to your story? Because I know your story is very unique and might be really interesting for people.
Sure. So I mentioned before that I had quite a pronounced loss of sensation in my genitals, penis. I'm still like 8 years old sometimes. Sorry. And so this was actually covered in a Spin magazine article, and some people are familiar about this, but I did some research and I found a novel surgery that was being conducted in the Netherlands called the Tomax procedure. And after about many months, almost a year of trying to convince ICBC and the folks in the Netherlands to make it all happen, it happened in May of 2021. I went over there during the pandemic, and I got the surgery done. Now, what the surgery is is ostensibly a nerve transplantation. There's a nerve in your groin. They take the penile nerve, and they can do it on one of two sides, or both sides. And my side that was pretty much had no sensation was the left side. So then they took the penile nerve on the left side, they grafted it to the nerve in the groin on the left side as well. And then yeah, the whole thing took about, I was there for about 23 days. It was a very challenging, I'm going to say 3 months afterwards. But I just wanted to come here today and report that the surgery was extraordinarily successful for me, where I now have increased erectile function, significant return of sensation throughout the whole penis, including the shaft part, which I was not expecting, and also that I can reach climax where I feel it coursing throughout my body, and there's a lot more to it. It took a lot of work, believe it or not. You have to retrain the brain because for a good, I would say 15 months, if I would touch the left side of my penis, it felt as though I was touching the inside of my left groin. So I had to actually train the brain to make a new association, and also train the brain to think that that's something pleasurable, because it's not at first. It felt like someone's just sort of like had one of those like pins, you put into the corkboard, and was just doing that for a while. But yeah, I'm happy to report that after 3 years, it's been amazing. One thing I will note, I was really fascinated by the psychogenic and reflexive different types of stimuli and erection. The doctor told me that when I got the surgery, do you want to do both sides or one? And I said, well, maybe we'll do both. And he's like, well, hold on. If we do the right side, which had some sensation, limited sensation, then I wouldn't be able to get any kind of reflexive anything, because once you cut that nerve, it's purely psychogenic. You can only achieve an erection psychogenically. And I thought that was kind of fascinating. And it's transformed elements of my sexuality, definitely. That so for instance, here's like a kind of more safe for work thing I could talk about. So audio is way much more of a stimuli than it was before. So whereas visual, yeah, sure, but way more now. Reading erotica or listening to a story is way more exciting for me, or an idea, than it was previously. So that's just a little, like, just some detail and just a bit of reporting back from the surgery.
Thank you, James. I really appreciate, again, you sharing your story. And really, I love the fact you brought up what was gonna talk about, but I'll spend less time talking about, is the neuroplasticity aspect that you described, like retrain the brain. And sometimes that's a hard concept for people to get, but you're just like the poster child for that. If I can say that, to retrain the brain. So really, I want to focus on that. Neuroplasticity is really the brain's incredible ability to make adaptive changes and just rewire itself. And these things you can see are sort of connected, right? Ways of enhancing that neuroplasticity. Like one way, obviously, is the surgery, the Tomax procedure that James described. But also, it's interesting, you had to do a little bit of sensate focus after, and retraining and body mapping. And sensate focus is being used forever, like since, I want to say since Masters and Johnson's in the 60s. But it is a tried and true way that we do coach people about, and it's just the purpose is to utilize different types of touch and different parts of your body to basically map areas that bring pleasurable sensation. So like I talked about before about, it might be the ears, the neck, the breast, and combining that touch with erotic thought and arousal. And like the audio that James is talking about, and just keeping an open mind around that. And I think, yeah, it takes a lot of practice. The other positive thing we've had results from is mindfulness. So I'm sure most of you have heard of what that is. So it's basically being in a non-judgmental state of awareness in the present. And that has real advantages in terms of sexual rehab. So in improving that mind-body connection, in pain management, stress reduction, and like self-compassion broadly. So exploring, I just want to make a note of exploring different sexual practices. So for example, like BDSM, or kink, and for some people, because this uses the whole body as a sexual organ, this might be helpful for people that have experienced changes in sexual response and in their body sensation. And an important point is primary components dictate that BDSM practices are safe and consensual, and where there's focus on communication and respect and trust. New scientific discoveries. So beside the surgery thing, I just wanted to mention the new work that's being done in epidural transcutaneous stimulation, and we're doing some research. People are doing research in this area in terms of sexual function. So that's kind of on the horizon too. Trying to move my slide. Oh, and I put all of these things I think really require not just consent, but good communication, and that comfort level, and the remaining open to possibilities. So a little bit about dating relationships. This is one of the common questions that we get, and maybe we can end on this. I think, yeah, a lot of people worry about when to bring up issues around bowel and bladder and sexual function with a potential partner. So again, it depends, it's so individual, and we encourage people just to develop that trust and just communication, try and be open, and depend on the situations. I'm reminded, just give you one example of someone I worked with years ago, and we actually presented together, and he identified as a gay man with a spinal cord injury, and he described this like double closet phenomenon as in terms of he came out many years before as a gay man, and then he felt like he had to come out again as someone with an invisible disability. So I thought that was very, very interesting what he described as that. So I'm not going to belabor this. So this is just some questions that we give to couples to maintain intimacy and build that adaptability. The bottom line is couples adaptability is about responding to life-changing circumstances with good communication and a lot of flexibility. And that's a quote from Esther Perel, sex therapist. Here's a couple of resources I highly encourage you to take a look at if you haven't done already. So this fantastic SCIsexualhealth.ca site that was developed in partnership with Spinal Cord Injury BC is constantly being updated. We're really proud of it. It's got tons of great information that we just kind of skimmed the surface today. And Skyer Community has some great research evidence and a chapter on sexual health. If you would like a referral, if you haven't seen us, even if you've seen us before and you want to come back to our service, you can go on the vch.ca website and get our referral form. So any clinician can refer, but if you have questions, if you don't have a family doctor or a nurse practitioner, by all means, get in touch with us by email or phone, and we'll try and sort it out for you. We don't want that to be a barrier. Right, Rachel? Right. Okay, so I will end here and open the floor for questions.
Appreciate
And
it. Thank you very much.
and I'd like to thank SCIBC too, and James.
Yeah, that was awesome, James. And just letting people know that we will be sending out these resources for people that signed up if they want them, just in case you didn't get that. So we will open it to questions. You can throw it in the chat. You can put your hand up if you can. You can put the little hand icon in there and we'll call you out. I did have a question. So you mentioned pain, spasms, and fatigue. Seems like that's kind of a barrier to a lot of things in this world. Is there a point that you would recommend that maybe somebody would loop in their medical team to explore medications or other ways to kind of alleviate, especially like the spasms and fatigue parts? And then this is a question to anybody that wants to, from the sexual health team, that maybe want to jump in.
I can jump in. That's, certainly we work with interdisciplinary team members, right? And so sometimes we'll see someone and we realize, you know what, like you haven't had a physiatry review in like 6 years.
And it's hanging down.
And so anytime I see that, I say, if you're not optimizing your overall health, that's going to impact your sexual health, as I kind of mentioned in the beginning, right? If no matter what's going on with your health, if it's bothersome to you, it's just gonna impact your sexual health. So certainly, Ryan, yeah. And there are some certain considerations when thinking about, like, if somebody's on baclofen, it may not be the best time to take baclofen, like just before sexual activity or a couple hours before sexual activity. So we can provide some education around, like, timing for medications, and certainly there's some medications that have more impact on sexual function than others, and those are things that we can talk about and kind of weigh the risks and benefits, and yeah.
Quick question. Do you people work on the island, or would it'd have to be through a Zoom environment?
I could take that. Yes, we do see people on the island, most definitely. And yeah, it's usually virtual.
Okay.
Because we are based out of Vancouver Coastal, but definitely we see people from all over BC.
Okay.
Thanks for the question.
Maybe one more while we're here. As you get old, as I get older, I'm about 37 years into this break, and I'm finding I'm losing a lot of nerve endings, a lot of muscle mass, and sexual function. Is this normal? Is it just like an ordinary 68-year-old would go through this stuff? And is it just amplified because had the incomplete?
Yeah, Rachel, you can chime in here too. Yeah, unfortunately, as we age, we all succumb to like those changes with age as well. That said, I think we always do investigate. And when people tell us, especially if it's a new change in their sexual response or desire, we would investigate and look at the big picture, like hormonal levels, medication changes, changing in relationship, because there's so many things that can impact sexual functioning. So yeah, I wouldn't just throw it out. I wouldn't just dismiss it as age, and that said, also Rachel and I and the team, there are lots of ways, like non-pharmaceutical methods and medications that can support people in their regaining sexual function. Yeah, so we'd explore all the options and the underlying what's going on reasons, and then try and address it, in partnership with you and your healthcare team.
Thanks, it's good. Appreciate it.
Okay.
Someone was asking about monthly meetups and resources. So just to let people know, there is the Incomplete SEI group that meets the first Thursday of the month. For Kate and Rachel, would you know of any sort of supports? Because I know we do have somebody here that lives outside of Canada as well. Would you know if there's any sort of support that might go beyond BC, whether it's a virtual meetup or it's anything on the table, really?
Do you mean around sexual health specifically?
Yeah.
Yeah, I mean, there's pockets of people across the country and other provinces that connect with us.
I do know, like I don't know that I can necessarily endorse them, but I have seen that there are like disability and sexuality groups that exist on platforms like such as Facebook or Reddit that aren't necessarily an in-time meetup, but you can post a question, have a peer respond, and that type of thing. So those certainly do exist, although, you know, they're obviously not moderated by us, but they do have some really great, interesting information at times, I've noticed. Sometimes I will kind of take a peek to say what people are talking about and get some education myself, but some of them are open and public. Some of them you have to apply to because they're a little bit more private, but that's a good place to kind of connect with peers about this topic. Mm-hmm.
Yeah, there's some Discord as well that's specifically spinal cord injury and sexuality.
Are there similar clinics in the US? Do you have any colleagues down in the States?
Yeah, we do have colleagues in the States that have for example, like fertility clinics and do this work. Yeah, it depends where, but probably Dr. Elliott would be the one to have the most recent information about, depending on where it is.
Okay, for our friend down in the US, maybe I'll reach out to Dr. Elliott and see what she can come up with, and I'll get back to you on that.
Yeah. Again, there's pockets of people doing really great work. Yeah.
I have a question for Kate. Do you know if Dr. Elliott is starting to integrate Tomax into a possible, like, I don't know, solution for people when they're acute, or talk about it with clients?
Yeah, it's not, as far as I'm aware, she's not discussing that. And I'm wondering if that's a more something that we'd refer people to the urologist. I know we don't offer it in Canada, right? That's why you had to go elsewhere, James, right?
Yeah, I know, but I was talking with Dr. Kavanaugh, and it's not dissimilar to some transgender sexual reassignment surgery that trans men undergo. And so it's not beyond the realm of impossibility that that it becomes to Canada, and also University of Washington. They've done it, but that's more spina bifida related.
Right, interesting.
I do think you made a good point, James, in terms of, you know, we do all types of nerve, well, not all types, but a few different nerve surgeries to regain hand function, right? And if sexual health truly is part of our overall health and just as important as all these areas, then why isn't there perhaps more of a push behind doing these types of things? And that's, I always get a bit disgruntled that, you know, the Viagra and Cialis and things like that aren't covered as a medication because it's, you know, just for fun. And so there's a broader conversation behind, like, you know, the barriers that we still have in society around how we view sexual health as just something, you know, as a frivolous kind of part of our life and not actually integral to our well-being as humans. And so we're certainly like advocates for pushing things forward, and, you know, maybe there will start to be more of a conversation around that. Who knows, right? But we're really, you know, blown away to hear about your experience. And of course, we can't generalize to everyone because everyone has their own situation, but you make a good
point. Well, actually, that's why there's a bit of urgency, because so for men under 40, you know, especially under 35, there's a much higher likelihood of there being a successful outcome. Whereas, you know, and I don't think chronic or acute really matters, it's the age of the person. So from what Dr. Overgore is seeing, so like when people are over 40, into 50 and 60, it becomes increasingly less likely that there'll be a return of sensation. So that's kind of why I feel like it's important. I'm kind of like a champion for getting this surgery going. More of a comment.
Thanks, James. Comments are appreciated. Just letting people know we're technically in
Yes.
the 15-minute break zone, but I think this is a really good conversation. We do have a couple more questions. So if the team doesn't mind answering a couple more, if people need to step away, they can. We're going to convene back in 15 minutes and then lead into the next session. But we did have a question. How do we deal from damage to libido from meds used to treat injuries such as SSRIs, anti-seizure, opiates, muscle relaxers in the past and weaned off, and still lasting effects to regular people as well as spinal cord injuries?
I was on baclofen for a very long time, probably 6-7 years. And I felt it was changing things, and I slowly weaned myself off, and it got back to well, as regular as can be for someone with an injury. But yeah, I found it was detrimental after a while, long periods of use.
Thanks, Roy. I think that this question isn't a simple one to answer, right? So it never is in our department.
No.
There's never like a one-word answer, right? But I have read some literature that there is more recognition that the medications Janova mentioned can have more of a long-lasting impact than was previously thought. So although that is being more recognized, unfortunately, I don't know that there's a simple answer. I'm not saying that there isn't an answer. There's many things that we can do to support sexual drive, right? That's the good thing, is that we have lots of different tools to work with, but I would encourage them, if they can, to make an appointment with us and have a discussion.
Yeah. I was just more speaking on my experience. I found that there was an uptick after I got off the baclofen.
Yeah. If you can talk to your team about, I guess this person said that they weaned off and they still have lasting effects. I'm not sure how long they've been off for, but hopefully, Roy, as in your case, maybe if it's a long enough time that they'll see some return, right? Yeah, sometimes it just takes time.
I can speak more about that. Hi, I was just busy for a minute. I weaned off some of these medications over a year ago, and I still have damage. A lot of them were used for many complex chronic health problems. I also ended up with Lyme's disease at one point and many other multiple things. So I didn't have much choice and tried things in pain clinics. So I'm in a lot of pharmaceutical groups for people around the world. And there is permanent damage even when you come off some of these SRIs, things they use, like basic things like amitriptyline for fibromyalgia. Like I used a lot of them for pain and sleep, not really psychiatric issues. And they seem to have that problem when you're on them, but also when you come off of them. And that seems to be a common theme, like with people without spinal cord injury. So then you add a spinal cord injury and it's sort of like a double whammy, right?
Yeah, I hear you. And Kate's been in sexual health a lot longer than I have, but I feel like just in the last few years, I've been hearing more concern around this from patients. So unfortunately, although I don't have the answer or the cure or a simple answer, I certainly hear you and validate that you're not alone in that experience, unfortunately. So I just think what it speaks to is there needs to be more of a conversation with healthcare providers when you're getting on a medication. Not that it's the patient's responsibility, but, unfortunately, a lot of times we're not given all the information about medications. And so just asking those questions, and of course, mental health is important, and we always want to find a balance. But, I've had patients say to me, they put me on this SSRI and they didn't tell me that it was going to have any effect on sexual drive. And I never would have gone on it if I knew, right? Because they said, now I'm even more depressed that I can't have an orgasm. So there needs to be a balance.
Yeah, I think we need to promote more education in spinal cord injury. Like if people can know, like ahead of time before trying some of these medications, what the risks might be, that might be helpful, like more advocating, right? So that, okay, you get a spinal cord injury. and you learn, okay, you might take this medication for nerve pain, but because no one told me anything about any of these side effects when I was taking them in pain clinics. Yeah, it's not until I went into other pharmaceutical groups with other people who weren't using them necessarily for spinal cord injuries, but other things, that I learned the common ground.
Yeah, I had a really bad experience with lamotrigine as well. Yeah.
Thanks for sharing, guys. Maybe this might also be on the medical side, too much on the medical side, but any injuries with incompletes that make orgasms totally not attainable? This particular question, they seem to be quite frustrated.
Yeah, it sounds like, this person, am I hitting a head against a brick wall? Well, I mentioned that it's definitely possible. And then the literature says between 40 and 50% of individuals with SCI. They actually said the more incomplete your injury and the more, that makes sense, the more genital sensation, the more chance you can relearn that sexual release. I think the other point that I tried, but maybe I didn't do a very good job, is moving from this this kind of goal of orgasm and looking more about pleasure. So when we work with people, whether they're single or with a partner or partnered, that we definitely try and help them through that, focus on all those aspects, those elements of neuroplasticity that James was talking about, and sensate focus and body mapping, and focusing on pleasure. Because I find that more people focus, what it's like the more you focus on getting somewhere, the less likely you are to get that and into the frustration with that, right? So I think if you can move away from that and look into more what feels good, what's pleasurable in them, and be in the moment, and being, we always talk about those, like Rachel said in the beginning, the rehab principles of trying to maximize your potential, limit your changes, and focusing on open mind, being open-minded and flexible. But
there are
easier said than done.
There are some specific, physical things that you can try, right? For women specifically, there's been some research that they've done with women with spinal cord injury, believe it or not, giving them internal sexual devices to stimulate the cervix, and done brain imaging on them to see what's happening. And there's the vagus nerve. If you've heard of the vagus nerve, it doesn't connect through the spinal cord injury. It actually bypasses the spinal cord. So there's some research that shows that a deeper vaginal stimulation where the cervix is can stimulate the vagus nerve and cause orgasm that way. Although, that quote unquote orgasm may feel very different than it did previously, right? And so although orgasm may be possible, some people, they go, oh, I think that wasn't orgasm, but and that might be part of my sexuality, but it's not the end all be all, right? So just to say that.
Really appreciate it. On that note, we're going to make a little time just to get our other presenters in. I'd like to go back to one of the first lines one of you said, sexual health is health. Really appreciate it. So Rachel, Kate, James, thanks a lot for sharing and providing some really good information.